Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Hope everyone's having a great May and that you had a nice weekend and that you're ready to get started for the work week. So today my topic actually is a news flash I got, but it kind of goes along with what we're dealing with still under the public health emergency. And I've had a couple of practices come to me and say, we have a problem. And so I was taking a look at this and I did some research. And I'm wondering how many of you have actually checked your state's pandemic plan to make sure that the 1135 waivers that Medicare put out do not conflict with those requirements. So there is a website that I was looking at called Accreditation and Quality, and it's a compliance center that's also an extension of Decision Health and also Medicare. And one of the things that I thought was interesting, so if your healthcare organization has taken advantage of the federal 1135 blanket waivers during the pandemic, make sure you review those waivers as you prepare to survey to check if any were inconsistent with requirements under your state emergency or pandemic plan. I'm finding that practices now are finding that they're having to not just change their compliance situation, but possibly they may have to send in some refunds. So the blanket waivers, they do remain in effect as long as the PHE is in effect. And we know that that's right now until July 20th. The CMS surveyors and accreditation organizations, okay, so we call those AOs, in general, will be held to allowing those blanket waivers. However, they apply to requirements for federal programs, and some of those waivers could be superseded by requirements set by state or local authorities having jurisdiction. If that is stated in a particular waiver and is included in your state's emergency and pandemic plans, you might have a problem. So let's take a look at this real quick. This kind of reminds me of when the Medicare came out and said, when CMS came out and said that providers who are retired or did not have a current medical license during the pandemic, they could now offer services under the telehealth to slow the spread because we were short of physicians. But they didn't say anything to practices about check your malpractice insurance. Make sure that you can see patients on audio only versus audio and video. Make sure that it's, you can see, your mid-level providers can see those patients instead of just your MDs or DOs. And so this has been definitely a problem because in the practices and my clients that I was very diligent in the beginning in saying, we need to check that first. Let's not just because somebody says you can do it, let's make sure that you can do it. And 50% of practices did not have coverage for that. And I had doctors that were, 80 plus years old saying, yeah, I'm going to come out of retirement and do some help, telehealth because I can. And then now it's become where it's not even, in my opinion, all the time medically necessary. So this is where we have to be very cognitive of what's going on. So Secretary of Health and Human Services, HHS, currently, Xavier Becerra, he reauthorized the PHE on April 21st. So by law, federal law, that means the PHE is good for another 90 days. I've mentioned that because it's only 90 days at a time. In this case, through July 20th. Now, in January, the acting Secretary, Norris Cochran, notified the nation's governors that he would give them at least a 60-day notice before declaring an end to PHE. Okay, well, this is our 18th this is a May 18th podcast, and so that means is he's sending an email saying it's going to end July 20th on Thursday. We don't know yet. So the blanket waivers were designed to give hospitals and obviously other healthcare providers such as yourself a spectrum of flexibilities from requirements under the conditions of participation and other regulations. So, but CMS has been very clear that while the waivers are in effect through the term of the PHE, once that ends, so do the waivers, and hospitals could be held accountable for any backlog of maintenance, testing, or fire safety requirements as well, specifically waived by the 1135 declarations. Also remember, you could be responsible for HIPAA issues, for share of cost issues, and it's also worth noting that the interim director at that point said that the federal public health emergency is different from any emergency declarations by individual states, which they have their own set of emergency requirements. So even at the federal level, the president's declaration of an emergency is different from the HHS Secretary authority to declare a public health emergency and issue the blanket waivers. Tongue-tied this morning. So what this means is that states can set their own emergency requirements in an emergency preparedness or pandemic plan. And this can be confusing, especially because some governors in some states are declaring the pandemic emergency to be over and lifting social distancing, masking, and other public safety guidelines. Those guidelines are different from specific pandemic-related regulations and other requirements for healthcare providers, which could remain in place unless otherwise stated by local or state public health officials. So as I'm reviewing these waivers, reminding hospitals they should remain aware that some of the federal blanket waivers say the specific flexibility is allowed, quote, so long as it is not inconsistent with the state's emergency preparedness or pandemic plan. So I'm dealing with some hospitals on this now too, because that means at the end of the PHE, or as it approaches, hospitals need to be very familiar with their own state's emergency plan to ensure that they're in compliance. Also, not every waiver has this phrase, which adds to the confusion. So as an example, for anesthesia services, under the 1135 waiver, it states, and I'll quote, CMS is waiving requirements under 42 CFR 482.52A5, that's a mouthful, that a certified registered nurse anesthetist, CRNA, is under the supervision of a physician, and then it goes on to which paragraphs. It says CRNA supervision will be at the discretion of the hospital and the state law. This waiver applies to hospitals, critical access hospitals, and ambulatory surgery centers. For those of you that own those, listen up. These waivers will allow CRNAs to function to the fullest extent of their licensure and may be implemented so long as they are not inconsistent with a state's emergency preparedness or pandemic plan. So if a surveyor were to find that there was an inconsistency between the 1135 waiver used in this example and the state restrictions, they are required to defer to the state regulatory requirements. So if your hospital or ASC is unsure, whether an 1135 waiver is consistent with your state law, you need to check your state emergency preparedness and pandemic plan and go with that. Incident command centers. So those are slowly closing. So remember, you did not have to make a specific request to CMS to qualify for the blanket waivers. You remember with the provider relief funds, they just kind of dumped them in our account way back in April of last year and then again in November. But the Joint Commission and other accredited organizations have said that triennial surveys are resuming as normal, and that started March 1st, if you didn't know that, meaning that they will be unannounced and on-site unless the hospital is in the middle of a COVID-19 patient surge and incident command center is still active to deal with the PHE and is considered unsafe to go on-site. But again, now they have numbers as far as what that means per capita. In late April, incident command centers, the activation was unnecessary in many parts of the country. And so because many hospitals are not utilizing their incident command center and they now have well-defined processes in place for screening, isolating, and treating patients, that's when now the accreditation process is now stepping up again. So it's common to see hospitals continue to include COVID-19 patient numbers and also patient location in the daily safety huddles, leadership reports, of course, infection prevention, surveillance rounds, but the incident command is not needed in many cases for daily management of COVID patients anymore because now, they figured it out. So the reason I mention this is as a consultant, I'm one of several consultants across the country. I've been busy helping hospitals and other organizations. Mostly I deal with ASCs, but prepare for upcoming accreditation visits, many of which are overdue because remember those surveys were suspended at the start of the pandemic as of the end of March. So as I'm traveling from hospital to hospital, week after week, and I'm trying to stay a little bit local for right now because I'm not flying right now. The hospital level, the staff, they're just remarkably resilient. I just really impressed with them. But the nurses are saying, we're following our policies, using proper PPE, cleaning and disinfecting properly, and then working as a team much closer than ever, managing COVID-19 patients. And they're also happy to see that the surge is lessening because of the vaccines. They still will see some small surges, but not enough, I'm anticipating, just from what I'm seeing, to get ready for some of these accreditations. Locally here, I've already had 2 accreditations for ASCs with JCO, and they just showed up and they just said, and they weren't clients, so they weren't ready. And immediately I get a call because when they show up, they're saying, okay, we're going to give you a 48-hour window if you ask for it. And so we had to go in and just make sure everything was, up to standard. But just remember that this can be, just very, very daunting. If somebody shows up and you're not prepared, if you haven't looked not only and reviewed all of the waivers that are still in place, and remember now we're up to 180 pages. Those FAQ sheets are now at 5/6, so May 6th was the last one we got. But you just have to really understand that the public health emergency is a distinctly federal concept, and the current PHE is national, but it's not the same as what you have for state level PHEs. And so, a lot of different AOs will be following CMS's lead as surveys return to normal, but it's just really important that you keep in touch and in mind, not just with your malpractice, but your liability insurance, but also what your state is doing. And it's just really about accreditation, about compliance, and just making sure that you're covered. I would really hate to see anything kind of get weird there. Now, I wanted to move on to another topic. So this is kind of a dual topic day. I'm seeing many healthcare organizations, mostly the bigger ones, but many different sizes that are trying to get back to outsourcing the revenue cycle management. I just wanted to comment on that for a second. Now, for those of you that know me, I am not a fan of outsourcing. I'm just not, mainly because whenever I think of outsourcing, I think of offshoring. And that means, sending your claims and your billing and your collection responsibility to someone outside the country. And to me, you can't manage that effectively. So think about what happened as we went into the pandemic. I had practices that I was like, what did you do? So there were situations in which some large academic health centers that were 100% outsourced to international companies. And when COVID first came through, it came through more so in those areas like the Philippines and India, where there's larger hubs of offshore outsourcing, and they didn't have a contingency plan. So this unprecedented public health crisis really hurt a lot of practices. Now in the US, it seemed to be a little bit easier to pivot, to send your staff home, to try to get them to work from their home space. The only thing I thought was a little challenging, and I'm still believing that's the case, is a lot of staff members that went home didn't really have the space to work from home, but they made it work, and there's some HIPAA issues there, but hopefully that's been, for the most part, handled now that we've been in this closer to 15 months now. But one of the things that I just wanted to comment on is before you decide to do that, regardless if you're basically sending things out, outsourcing offshore or domestic, make sure you have your eyes on that vendor. That's what seems to be overlooked in the healthcare process. And I can't say this enough. It gets back to the basics of vendor management. Are you understanding the capabilities of your outsourcing vendor? Do you even know what kind of internet they have? Are they also outsourcing your business to somebody else to help? Make sure that's part of your contract if you decide to do that. Again, I'm going to discourage it I'm going to discourage anything offshoring. Outsourcing, if it's within the U.S., that's going to be something you have to decide on your own. But you have to know when you can meet with them, what their customer service is like. But you have to be very regimented and stick to your own rules that you had in the office. Make sure you have an agenda laid out. have expectations of what people are going to discuss. Make sure that you know what they're bringing to the table. If they tell you they have certified coders in certain specialties, make them prove it. Don't just take anybody's word for anything. I see that so many times, and I get these calls, drives me crazy, with a lot of billing companies that say, we can do this. And then they call me and say, hey, I just had one yesterday. I picked up a new client and we don't do cardiology. Can you look at all these reports for us? And I said, why would you pick up a client that you don't know the specialty? Well, I know I can usually find somebody to code, reports for me. I'm just like, oh my gosh. So I'm coding these reports and sending them back. And obviously we charge for that. And the thing that they came back with, well, that's too expensive. I'm like, well, that's what we charge. So, and obviously, that's something that was paid, but this is something that you just have to be mindful of. I see a lot of practices that come back to me and say, we went with an outsourcing company. We didn't know that they outsourced a lot of things to India, or to, there's one, I can never think of the acronym, but it's Emeritus. And basically it's European out in that area. And they just didn't have a lot of information that they were able to contact. There's different times when you can actually get a hold of somebody. The access was inconsistent. They didn't understand the scale of the operations, and they didn't understand your specialty. And so as we are really looking to maximize our dollars and make sure that we are doing what's best for our practices so that we can rehire staff, keep staff there, just make sure that as a provider, as an administrator, as a manager who's listening to this, make sure that you vet revenue cycle outsourcing vendors properly if that's where you're heading. If you're going to eliminate an entire department, that's not something you take lightly. So providers will need to return to your mission in order to implement the right solution for optimizing your revenue cycle management. Your revenue capture is just so important. You don't want to leave it to people who are not professionals. I had one company that I asked them when I did an audit on them, actually. So a very big practice in a Chicago area said, can you audit this? Our revenues have gone down. They outsourced almost 80% of our coding and, and billing and all that. And when I did, I couldn't believe what wasn't captured. I was 2 hours into the audit and I found almost $3 million that wasn't billed. It was insane. And so I said, I need to talk to, your company that you're using. And I said, where are you getting your information from? And you know what she told me? Facebook. And I was like, oh boy. So this is where you have to be very diligent in who you're hiring, what you're looking at, even the consultants. Make sure that you get, referrals, that you understand who that is, have somebody you trust. I know I have clients that have been with me 30 years. They're like, we wouldn't go to anybody else. So you want to make sure you have that trust built up. You know what that person's insight is, education is, certifications are, and what they can do for you. And so I just wanted to put that out there because right now I'm seeing such a problem when it comes to really making sure that you are not outsourcing things that you aren't aware if they get offshored, and outsourcing something that really should stay within your practice. And so I know I kind of got a little soapbox on that, but that just concerns me. I just really want to make sure that you're covered, that you're protected, and that you know what is important for you to provide. And I know you want to focus on getting the best providers in your practice, hiring mid-level providers, things like that. But if you don't put time and energy into making sure that your billing processes, your technology for your process, your workflows, your billers, your additional hires, if you don't understand how all that is, your collection rates, then you're never going to have a successful practice. That's called the business of medicine, the business of healthcare. And I dive into that with a passion. So hopefully you'll find that helpful as far as the information. So I have 2 coding questions this week. One is, actually both of them are cardiology. One is for the ICD-10 choices for carotid artery stenosis. So if your cardiologist provides adequate documentation, you'll select the appropriate carotid artery stenosis code from either I-65.21 occlusion and stenosis of right carotid artery, or I-65.22, which is the occlusion of and stenosis of the left, and then you have I-65.23, which is occlusion and stenosis of bilateral carotid arteries. So if your cardiologist doesn't specify the side of the patient's carotid artery stenosis, then look at I-65.29 because that says unspecified. Now, I'm just going to give you just a heads up caution. If you always code the unspecified, you do two things. First of all, you run the risk of not getting paid because it wasn't specific. But secondly, there's a reason there's a specificity within the I-10. It's so your doctors aren't being lazy when it comes to their coding. Make sure that it's in there, because if you have to treat one side and then eventually treat the other, you're not going to be dealing with global days and things like that and having to adhere to some of those rules. Another question was, so Terry, I think I missed the errata when it came to the 2021 updates. Was there anything for cardiology? So I don't think somebody was asking me about the 2021 errata for E&M, finally. It seems to be that's all I've been doing lately is updating on that. But there were two for cardiology, and these are technical corrections. So if you've ever heard the errata, that means that there's technical corrections that were made to the 2021 CPT manual. And it's an email they send out, and it's effective actually retro to January 1st. So first of all, the word catheterization was misspelled in the code descriptor for 33475, so that was corrected. The letter TE were added to make this correction. Also, there was an incorrect page number in the guidelines under Category 1 Medicine, Cardiovascular, Cardiac Catheterization. The guidelines said, please see the cardiac catheterization table located on page 682, but the page was actually 746. So just little things like that, nothing to really get too crazy about, very easy to find. So my personal tidbit this week kind of goes along with also work a little bit. So for the past, well, I guess because of the last 2 years, I guess I'm not going to be able to say 17, but the past 15 years, so it kind of stopped in after 2019, I've been invited to go and speak, as I know some of you have heard me say, in Hawaii for the Hawaii chapter APC. And it's been great. So that's also their Hawaii Chapter Coders Fund. So it's in conjunction with them. And because of the pandemic last year, the place that they had it shut down. And then this year, they couldn't accommodate. Usually they have 350 to 400 people. And they were going to have it at the Aulani in Oahu, which is a Disney hotel. And so what I usually do is I offer my services, and I just wanted to shout out to the Hawaii coders because I offer my services from a virtual standpoint, making sure they can still get their CEUs and do some on-demand recording for them. But I just wanted to say hello to them. I really, really love my Hawaii coders. They're just so nice, and they're always so accommodating when I come out, and I can't wait to see you next year. So Jerry Leong, we love you, and also Shar with the Hawaii Coders Fund. So thank you again for always inviting me, and I really look forward to 2022 out there, but it's been a pleasure to provide those on-demand services. All right, everyone, have a great rest of your week, and I'll talk to you next week, which I am back with the Top 10 Tuesdays, so you will hear me talk about coding questions. I've received a lot of them this month, and so we're back to that at the last Tuesday of the month, and so it'll be the top 10 coding questions I've received through my Coding Corner membership. Also, for those of you, I do know that I've been getting some questions, just random questions. Please take a look at my website at terryfletcher.net. Go under Services, and the very top option is for Coding Corner membership. We have 2 different memberships, and that's for unlimited coding questions through email. Because we get so many coding questions, almost 100 a week or sometimes more, we do ask that you be a membership. So you are part of the membership to be able to get coding questions answered. So we research them out for you. We make sure you have a paper trail, and we just do a lot of work for you. So we do ask that you're part of the membership. Okay, everyone, we'll talk to you soon, and thank you again for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.